1. Introduction. Snakes are widely distributed in India, mostly in rural areas and in jungles. Most of the snakes are, however, non-poisonous. Only 35% of snakes found in India are poisonous. 2. The poisonous snakes in India are A. Indian cobra, Naja, Naja. B. Common krait. C. Russell's viper. D. Saw-scaled viper. E. Pit vipers. F. Sea snake 3. Distinguish between poisonous and non-poisonous bite poisonous fang marks, present bite marks, usually small in numbers. Symptoms of envenomation, present. Nature of bite. Defensive behavior in cobra, they rear up, spread hood, hiss, and make repeated strike towards aggressor. Russells produce hiss, and saw scaled viper produce grating rasp. Non-poisonous fang marks, absent bite marks, large in number symptoms of envenomation, absent. 4. Clinical features, symptoms and signs. Local envenomation, pain, induration, crepitus, bleeding, cellulitis. Hemotoxic/vasculotoxic, viper bite. Signs of intracranial bleeding, hematuria due to urinary tract bleeding, tachycardia, hypertension, renal failure, signs of intracranial bleeding, neurotoxic, cobra bite and krait bite, drowsiness, blurring of vision, ptosis, respiratory muscle paralysis, total paralysis, convulsion or coma. 5. Factors affecting snakebite. A. Amount of venom injected. The amount of venom injected will be less or absent if the snake had killed a prey just prior to bite, or if the bite is through a thick layer of clothing. B. Host factors. Snakebite poisoning is generally more serious in children because of small size, old age, and in debilitated individuals. C. Location of bite. Parts of the body. Bites on trunk and face are more dangerous than on the other. D. Physical activity. Physical activities like walking and running immediately after the bite increases the absorption and circulation of poison in victim. Management 6. In a case of snakebite, the management and examination has to proceed side by side. The important aspects are A. First aid management. B. Transportation of casualty. C. Rapid clinical assessment and resuscitation. D. Lab investigations. E. Anti-venom treatment. F. Supportive therapy. 7. First aid management. A. Maintain and support airway breathing and circulation. B. Reassure the patient and relatives and try to allay anxiety. C. Immobilize the limb. Immediately immobilize the bitten limb with a splint or sling, as the movement and contractions will enhance the venom absorption. D. Pressure immobilization. Ideally, an elastic crepe bandage of approximately 10 centimeters wide and 4 m long. Otherwise, a long strip of cloth can be used. The bandage is applied on the bitten limb, starting distally around the fingers, toes. The bandage is bound tight as would be for a sprained ankle, but not so tight to occlude the peripheral pulses. Pressure immobilization is not recommended for viper bite due to local necrotic effect. E. Tight arterial tourniquets are not recommended as they can cause more harm than benefit, which may result in gangrenous limb. 8. Transportation of casualty. It is of vital importance as it decides the survivability of the victim. One should avoid undue movement of the bitten limb, secure and proper splint age 9. Rapid clinical assessment and resuscitation. A. Inform duty medical officer. B. Try to identify the snakes as venomous and non-venomous, but do not waste too much precious time in doing so. C. C for rapid early extension of local swelling from site of bite. D. Look for early enlargement of lymph node. E. Look for early systemic symptoms, i.e. collapse, nausea, vomiting, diarrhea, severe headache, drowsiness, heaviness of eyelids. F. Look for signs of systemic bleeding. G. Look for anaphylaxis due to envenomation. H. Establish good intravenous access. 10. Lab investigations. A. Clotting time on admission and then repeat as necessary. WBCT. whole blood clotting time. B. Prothrombin time, platelet count. C. HB, TLC, urine, REME, DD, serum creatinine 11. Antivenom treatment. Keep antivenom and anaphylactic tray ready. 12. Complications. A. Acute renal failure. B. Shock.